I'm Dr. Jam Kothari.
And I'm Dr. Sally Moore. And this is a Myeloma Minutes, a podcast for people affected by myeloma, patients, friends and family.
Hi Sally, good evening.
Hello. God, it feels like it's been a while, doesn't it? Because we've had half term in between since we last spoke.
You've been cruising around the country in a camper van. I always knew you were a little bit of a hippie, but I think this has proved it.
Oh yeah, living my best life on pasta with a 6-year-old. It's been wonderful.
Pasta and 6-year-olds. One of those two things is one of my favourite things, and maybe we shouldn't define which one it is, but it's nice to be chatting with you again, Sally. We're getting towards an interesting time of year with the American Society of Haematology meeting coming up in just a few weeks. You're going to be jetting there, aren't you? And telling us all in live time what's happening.
I am going to try and properly take notes and get snippets for all our listeners. But yeah, looking forward, although it's such a difficult time of year because you're so excited about Christmas and then you're jet lagged in the States. But I mean, what a life. You know, life's hard, Jam, isn't it? When you're an international jet setter, that's all I can say.
It's a really exciting meeting, and I have to say I do really look out for when the abstracts come out. And what we hope to convey to all our listeners is, I think, stuff that really can immediately change their experience of what's happening in the field of myeloma, because clearly there's stuff that we talk about and put on social media and stuff, which maybe makes an impact in a few years, but it's the stuff that really can improve people's lives almost immediately. And we're seeing more of this stuff, actually. So hopefully, I think, we have a Christmas special that we're planning, and we're going to hopefully be able to share some really interesting stuff from that meeting.
Definitely. And I think that kind of leads into what we want to talk about today, actually, Jam, doesn't it? Because so much of what we tend to focus on is, what's a breakthrough drug that's coming through and this, that and the other. But there is really interesting research and understanding out there about the common side effects of treatment. And that's kind of where we want to go today, isn't it, I think?
Neuropathy. This word that is bandied around a lot, and it's at its most simplest, means damage to nerves. And the reason why this is talked about so much in myeloma is primarily because of one of the main drugs that has been used over the last couple of decades. But actually, it goes wider than that. And I think hopefully over the next 30 to 40 minutes, we're going to give everyone a good appreciation of what neuropathy is, the type of symptoms that it causes, specifically how it relates to how we treat myeloma and some specific drugs. And then we'll lead into, how we prevent it, which is the ideal situation. And if we can't prevent it, how we treat it.
There's a lot to unpack there, isn't there, really? But I think it's fair to say that if you have ever had treatment for myeloma or you're embarking upon it, neuropathy will come up. And not only is it a little bit of a mouthful to get your head around, but it's a medical term which we band around like talking about the weather. And we forget, don't we, that actually it doesn't mean a great deal to a lot of people until you explain it. So hopefully we can explore some of that today.
What does the word mean at its most simplest?
So neuropathy, which I'm sure many of our listeners will be familiar with, refers to nerves. As you know, so much in of our language and medicine is derived from medical terminology, which you can translate into day-to-day language. So if you view the neuro bit as nerves and the opathy bit is sort of an inflammation or pathology of those nerves. And generally what that means is actually pain or discomfort. But it may be that those nerves, as well as experiencing pain or discomfort, might have an abnormal sensation or just not be working as well as they ought to be in terms of what they're supposed to do, like controlling muscles, for example. So it's a word which describes an awful lot of problems that can occur with the nerves and that can have many sort of downstream consequences.
I'm not a neurologist. And as you know, Sally, anytime we bring up another speciality in this podcast, I'm always very, very kind. I was very kind to ophthalmologists. We love them. And neurologists are smart people, and they are some of the most clever doctors that I have worked with. And we need to just do a little bit of neurology basic education. And this is where I'm squirming a bit. But when we talk about neuropathy, that we have to broadly talk about two types and two different types of nerves. We have something called the autonomic nervous system. And these are nerves that do things like control blood pressure, help digestion, It's very important in sexual function, and it's separate to the nerves that help us, feel our cup of tea and write and do buttons and walk, because we can feel the ground properly. So our peripheral nervous system, as it were. Now, that is intentionally a gross oversimplification. But when we as myeloma doctors, and all doctors, because many things can cause neuropathy and lots of specialities can get involved, you think about, is the symptoms that the patient is experiencing, is it peripheral neuropathy or is it autonomic neuropathy?
Do you know what? I remember learning about these two things at medical school, and it took me a while to get my head around it. But I always view the autonomic side of it as almost like things that happen automatically. Your blood pressure is controlled and you're not aware of how it's happening. It just does it. Your gut moves your food through your body and it just knows what to do. And that's the sort of the autonomic component. Whereas, as you say, the peripheral components are stuff that you might be more aware of day to day, like your cup of tea, for example. So yeah, it is quite complex, isn't it? And therefore, I think the diagnosis of these nerve problems is quite complicated, which is where our clever neurologists kind of help us out. And also for us to understand, in terms of the treatments that we offer people living with myeloma, which bit of their nervous system could be affected, and actually, is that really what's going on? So sometimes there's a little bit of detective work, isn't it, Jam, and trial and error to figure out what's what, really.
Even before a person who's been diagnosed with myeloma has got an anti-myeloma drug, can people have neuropathic or neuropathy type symptoms at diagnosis?
Yeah, it's a funny phenomenon, isn't it? I think this is often unreported, but actually, if you were to drill down and ask people directly at diagnosis, do they have an abnormal sensation in their fingertips or burning in their feet at night? I suspect more people than we would imagine would probably say, oh yeah, that's been going on for a while actually, and I didn't really put two and two together because I can cope with it, or I can stick up with it. So that's sort of like the individuals I would say have a silent problem, which tends to occur before the diagnosis is reached. But even if you don't have myeloma, but you've got a paraprotein related condition, the paraproteins can also go hand in hand with a type of neuropathy or different types of neuropathy, and you may never get myeloma, but still those two can be linked. So, and again, that's where it can get somewhat confusing. But would you agree, Jam? I mean, do you ask people when they're newly diagnosed if they have neuropathic symptoms?
Absolutely. And part of that is because I have a sense of the kind of treatments that I'm going to offer them. So understanding whether their nerves may be damaged already is actually extremely important, and it may move you to potentially omit or give certain drugs in a certain way. And that's where I think our understanding of sort of what we call general medicine and other things that can damage nerves is important. So diabetes is incredibly important and a very common cause of neuropathy. Things like alcohol, if people drink a lot, that can cause neuropathy, and certain vitamin deficiencies, things like vitamin B12 and folic acid, can also cause neuropathy. I always check things like the B12 and folate before starting treatment, and all myeloma patients should have an assessment of whether they have undiagnosed diabetes or pre-diabetes before starting any sort of treatment as well. And that's extremely important. Another thing, of course, is that myeloma can cause damage to the nerves because of what's happened, for example, in the spine. So unfortunately, if people are diagnosed with compression fractures in the spine, that can press on nerves, which of course can be incredibly painful. And you can get these shooting like sciatic pains, for example. Sciatica is a term that, is used very commonly, isn't it? But actually is a description of a typical type of shooting nerve pain that comes from compression of the sciatic nerve, or what we call nerve roots. So where nerves come out of the spine, which eventually become the sciatic nerve. That's not neuropathy how we've just described it, but it is damage to nerves caused by the underlying myeloma.
I'm really grateful for you raised that, because even just listening to you talk about it, Jam, going through my mind, if I was to draw a picture of how neuropathy may present or what the cause is, it gets very complicated, because it might be a lump pressing on something, a nerve around the spine, or it could be something happen in the periphery, the peripheral neuropathy. So in the tips of the nerves rather than in the sort of where they begin, almost in the spine or even in the brain, actually. So kind of unpicking all of this is incredibly important, like you say, so we know which treatments are safe to give, but also if, for example, you've got a mass compressing part of the spine, you also need to know about that to control that pretty quickly before it causes further problems. It is a bit of a minefield, really, isn't it? But I hope the longer we've practiced medicine, and certainly in the field of myeloma, the easier it does become for us all to navigate our way around it.
Certainly in myeloma circles, it's really been the last couple of decades that we've really thought about neuropathy, and that's both peripheral neuropathy and autonomic neuropathy. And that's sadly because of a drug called bortezomib, commonly known as Velcade.
Definitely. And we've been using Velcade for decades now, haven't we, Jam? When it came on, I know we've spoken about this in other podcasts, but it's really worth us kind of reminding one another and our listeners that when it came to market, it was a real game changer. Suddenly, this drug, this treatment appeared, which appeared to be particularly powerful in targeting myeloma cells. And therefore, as soon as we were able to give it, almost everyone was exposed to it. But what we were learning as we went along with using this drug in the real world is that there are different ways of giving it where it works just as well, but you don't get the neuropathic or the neuropathy side effects, or to such an extent. And so there are lots of people out there, some of whom may have been treated ages ago with Velcade for myeloma, who may still have problems with neuropathy now, because we were learning together then how best to use it. Whereas I hope people receiving this treatment now are less likely to get those complications. But I certainly remember people coming to clinic sadly in wheelchairs because it was so painful to walk, or they didn't know where their feet were. And I think you'd agree that that's now a pretty rare thing to see.
It is rare now, thankfully. I remember seeing someone who had such bad autonomic neuropathy that they couldn't control their blood pressure. So something that a number of our listeners will have had is people measure their blood pressure when they take this drug bortezomib, and people do what we call sitting and standing blood pressures. So you look for this thing called a postural drop, which for most people really means that when they stand up, they get dizzy. Again, I think because we didn't know how to give the drug, the poor patient could not sit up. They were just too dizzy. And they basically had to spend most of their time in a sort of semi-reclined lying down position. And the sort of route that has gone is that initially we used to give this drug intravenously twice a week. And now we have moved to essentially, in the vast majority of situations, giving it just as a small injection under the skin once a week. And that has definitely lowered the impact of the neuropathic symptoms. But Sal, I think now this is probably a good point to just sort of go through those symptoms. I mentioned one of the symptoms of the autonomic dysfunction. What sort of other symptoms might someone get if they have the autonomic neuropathy symptoms?
Really interesting, and it's really important. And I guess before I start explaining this, it's also really important to say that sometimes these changes can be quite subtle, because now we can moderate the dosing and the dosing interval. A good example would be your gut motility, which is a medical way of saying just, do your bowels open regularly? Are you constipated? Are you too fast? Are you too slow? And some people can notice that actually things just slow down a little bit when they develop this autonomic kind of component. Another issue, which can be quite problematic, and again, I wonder if we don't ask enough about this in clinic, can relate to sexual function, particularly in men. And men can experience sexual dysfunction because of autonomic neuropathy, which again, you can treat with the standard medication that we're familiar with that might overcome those problems, but that can interfere with intimate relationships and can be incredibly important. And again, you don't really know till you ask, and that's another potential significant side effect of this autonomic kind of component. So I think they're the three big ones I would think about: the tummy, blood pressure, and sexual function.
They're the major ones that we do ask about. I think the blood pressure one is the one that everyone is very good at asking, but I think you're right to highlight the other ones, Sally, because I do think they are sometimes missed out. And certainly the bowel ones are sometimes mistaken for other things, because constipation or problems with the bowel can be caused by so many different types of drugs that people end up taking.
Yeah, definitely. It's so hard, isn't it? Even antibiotics can upset our bowels and we dish them out willy-nilly. So it is quite hard sometimes, isn't it, to figure out which drug might be the culprit. Jam, to kind of like come back to you really, of course the autonomic component is really important, but so is the peripheral neuropathy. And we do ask more regularly, I think, about that in clinic. So I wonder if I could sort of bounce this back to you and if you could describe how that might manifest for people and what we're looking out for when we're quizzing people in clinic about how they're feeling.
So when nerves are damaged, it's often the longest nerves in the body where you notice the symptoms initially, because in our extremities, so in our hands and feet, those nerves have the sort of the longest way to go to get back to our brain to interpret how we're feeling. Our nerves are so clever and we can, feel and sense things. And that's to make sure we can do important things like pick things up and write and do buttons, for example. And then there's other things of knowing the difference between hot and cold, for example. And this thing that medically we call, proprioception, which is around understanding where different bits of your body are, basically. It's like finger up or down, and all of these things allow us to use our hands the way we want to and walk and move the way we want to in our extremities, that is. So a lot of the symptoms that we ask about are, do you have any abnormal sensations? Do you feel tingling, or do you feel any shooting sensations? Have you noticed that you can't quite tell whether something is hot or cold? You've become a bit more clumsy doing buttons, or writing has become difficult. Feet, for example, using a car. Have you noticed that when you're using the pedals in the car, that the way that you sense the accelerator or the brake has changed? Or even when you're walking. So sometimes it can start, and often, thankfully, it starts quite subtly, but it's really important for us to get a sense of these symptoms early.
The important thing to remember about neuropathy, if it does occur, if you continue to expose that person to the drug which is causing the neuropathy, it often progresses. To come back to sort of asking about the symptoms, particularly the peripheral neuropathy, again, I suspect you're like me, but I often ask people, do you have any tingling? Do you have any numbness? How are you sleeping? Because it's actually often when we're in bed at night, when everything else is switched off, all the other stimulus around us, that you might notice that actually my feet feel a bit cold, or my hands aren't quite right, or it's a bit numb. And that tends to be the sort of the earliest point at which a person might then recognise, actually, there's something a bit different going on here. And then, actually the neuropathy is there. Now, that may not be so bad that you need to do something about it at that point, but you definitely need to monitor it more closely going forward.
It's such a good question. How do you feel at night? Does it stop you from going to sleep, or does it wake you up from sleep? And sometimes that can give us a sense that there is something brewing here and potentially we need to take action. What is very good is I think they're very good and robust systems for asking about neuropathy now. That not only comes from us in clinic, but also from nursing checklists each time people come to their day treatment area, for example, to have their injection of bortezomib, and even for people who do it at home. So sometimes people will self-inject. They go through the same sort of checklist. So we have an objective view of how symptoms are on a particular day, and of course, how they may be changing week to week.
Peripheral neuropathy, the other thing to say about it really is because, for example, our fingertips are amongst the most sensitive areas of our body, along with our lips and perhaps our toes as well, that you are going to also notice it there, because that's where you need that sensitivity to hold your pen, to do up your button. And so actually making sure that you don't impair that function, because it's not a sort of a nice thing to do. We need to be able to hold a pen or tap on our computers. So it's really important that we also appreciate that sort of what we would describe as the functional component. How is this actually impacting on your life? Are you feeling like you're able to drive the car, as you mentioned, Jam? And if that is looking like it's becoming problematic, we may then discuss changing tack a little bit in terms of the doses or the frequency, or even stopping that treatment altogether.
And Sally, for the last few minutes, we've very much been talking about symptoms, like taking what we call the history, are there any tests that can help diagnose neuropathy, and, should we ever be using them?
There definitely are, and neurologists, our colleagues that we referred to earlier, are the experts in these tests. You can particularly do some tests called nerve conduction studies, which looks at how the electrical signals pass along the nerves, and that can tell you the type of neuropathy that someone's got. But we don't tend to refer our patients for that routinely, partly because actually the neurology clinics are pretty busy anyway, and that would really clog them up. And also it's another appointment that our patients might feel that they don't want to go to. But primarily because we're so familiar with this potential toxicity that I hope that we are skilled enough to be able to address it without needing those additional specialist tests. But maybe where we're stumped, we certainly might do that, or with slightly rarer hematological or blood problems, we might refer to our neurology colleagues to help us out with that diagnosis.
And if we're sticking with what we do with Velcade, Sally, you alluded to it. So they're very standardized approaches to reducing the dose or potentially reducing how often it's given. Or as you say, in certain situations, it may be completely stopped.
Definitely. I mean, I think what has changed in particular over the last couple of decades when we've been using this drug is we now can use it much more effectively, but also we're now using it in combination with other drugs, which are also more effective. And so therefore, it's not only is it not the only treatment we've got, but we're able to use it in a way which is much more measured, yet still highly effective. And therefore, I would say that you just do not need to trade off that quality of life or accept those toxicities, because if you're going to respond to the treatment and the combination, you will respond to it. And we can, to some extent, in near enough everybody, I think, with confidence, pull back on the dosing, and we will still, more often than not, continue to see a response. So I have a very low threshold for lowering the dose of the treatment and indeed stopping. Perhaps when, back in the olden days, we would have thought the neuropathy was quite mild, but now I tend to stop much sooner because I also know that when you stop the treatment, the neuropathy can progress thereafter before it gets better. And so it's not like you stop the treatment and suddenly someone improves the next week. That doesn't happen. And so I do think we have to tackle this sensitively and also just be mindful of actually what we're trying to achieve. But I mean, are you the same, Jam? Do you do that? Do you pull back early? I think my practice has definitely changed over the last sort of decade, I would say.
I think I have a much lower threshold for reducing the dose and potentially stopping. And that's because we're often using now 3 or 4 drug combinations where you've got other drugs that can do the job. You make such an important point about the fact that you can stop the drug and then the neuropathy can get worse. And that is not nice at all. If we talk about what we call the natural history, if someone has developed these, very unpleasant symptoms, will their nerves completely recover and the symptoms resolve if specifically we're talking about Velcade related neuropathy?
Yeah, I mean, I think if you were to be a purist about this and be a scientist about it, what you'd want to do is those specialist nerve conduction study tests and objectively assess the sensation or the pain that someone's experiencing to then say, in 50% of people, when it's this bad, it goes away completely or it doesn't. So I can't speak to that, but I can speak to my own personal experience. And I would say that in my experience, if you modify the dosing where you see neuropathy occurring, even at a low level, in the majority of cases, it will progress when you stop the treatment, but it should get better. Now, hopefully, that means that the neuropathy goes away for good. But in all reality, in all honesty, sometimes that doesn't happen. It's not unusual. Again, if you ask people directly in clinic, if you have the luxury of time, to really explain, really, are you sure you can feel your feet properly? Are you sure you're not getting any pain? Are you sure you're not feeling dizzy? It might be reported more frequently that actually, yes, those problems still persist, but they're not bothering me. I can cope with them, so that's okay. But I hope in most people it does get better, but it can take months and months.
And circling back to asking the questions, we have talked about this a couple of times, is people feel they have to grin and bear it. And if they don't take the full dose, they're not going to get the full effect. And we know that not to be the case. In the UK, we often combine Velcade with thalidomide. So thalidomide, unfortunately, is another drug that can cause really quite bad peripheral neuropathy. And this Velcade and thalidomide combination can be really quite toxic to the nerves. So any of you on that combination, really think about how you're feeling and discuss any symptoms that you have with your clinical team. Apart from those two drugs, Sally, all other myeloma drugs, some of them don't cause neuropathy. Do any others cause neuropathy or neuropathy-like symptoms that we need to talk about?
Yeah, we do see that, don't we? I think particularly, for people, younger people going through a transplant, first of all, not only you might only get the delayed effect of the neuropathy. In fact, I've looked after some people, Jam, who've had no or haven't reported any neuropathy symptoms while they've been on the particularly problematic drugs. But when you stop them, it then occurs. And sometimes if they then go on to maintenance treatment with lenalidomide, some people do report that their symptoms of neuropathy just become a little bit more apparent. Now, not massively worse, but certainly they're more aware of them. And again, when you then stop the lenalidomide, things tend to improve. So that's certainly a treatment to be aware of. There's another drug which is a tablet form of Velcade called ixazomib. Now, ixazomib doesn't cause neuropathy to the same extent, but again, I've noted that some people have experienced it with that medication. And I think they're probably the two culprit drugs that I would refer to. But do you have any other clinical experience with the other treatments that we prescribe?
I mean, thankfully, the newer sort of immunotherapies don't appear to cause peripheral neuropathy in exactly the same way. And we're going to get into those things a bit more in the new year. I think all those drugs that end omib, like bortezomib, you mentioned ixazomib, to a much lesser extent, carfilzomib, I think a minority of patients who take that drug can get neuropathy. And certainly that's one of the very big advantages of carfilzomib compared to bortezomib. But I think we've covered the main players. And thankfully, I think the use of thalidomide is going down significantly. But still, as I mentioned, in the UK, there are situations that we do combine Velcade and thalidomide.
Yeah, I mean, we're still prescribing that, aren't we, in UK practice, albeit that we hope that will change relatively soon. There's one point, Jan, that I'm really keen to make, and I know we've spoken about this before, but I just want to emphasise this for all our listeners. Neuropathy can happen, and as you said, sometimes, side effects occur and you've just got to crack on with it. But I think what's different about neuropathy compared to other side effects is that if someone doesn't share it, or they're not asked about it, or it's not taken seriously, whatever the reason, if that neuropathy exists and it doesn't get better, if you're then living with your myeloma for 5 years, 10 years, 15 years, 20 years, whatever that might look like, that could be with you for the rest of your life. And so it's worth flagging early, because you don't have to make that choice of living long versus having this side effect. Those two things, you can still get a brilliant response to treatment, and hopefully without this toxicity. So I think we increasingly are also having appropriately to look at the long game here, and it's our duty to do our best and work with our clinical teams and of course our patients to keep people as well as they can possibly be. And that definitely, hopefully, means not having much neuropathy or any at all.
Totally agree. So we have mechanisms of minimizing the impact. What about drug treatment, Sally? Neuropathy can be, unfortunately, painful. It hurts, and painkillers can be effective. And that's the kind of painkillers that we use for pain related to, headaches or myeloma bone pain, like drugs like paracetamol. Types of morphine can be very effective for certain types of neuropathy. But there's specific painkillers that have been developed to treat neuropathy.
Yeah, there are the sort of what we call anti-neuropathic agents. And there's a particular class of these drugs. Particularly, I'm thinking of gabapentin or pregabalin. They work in very similar ways, which we often ask people to take at night, which can help with their symptoms. Now, Interestingly, without the risk of oversharing, my mum has another neurological illness and she needs to take a lot of gabapentin. She often reports if she needs or she takes too much, she feels really woozy. So the only reason I'm sharing that is that these drugs themselves are painkillers, can come with side effects too. So I think you have to make sure you're getting the right treatment for the right person. But these drugs can be highly effective in lots of individuals. Or there's another type of drug, amitriptyline, which some of our listeners might be familiar with because it can be used as an antidepressant, but we use it at a slightly lower dose, which can help with neuropathic pain. Or even some creams, which you can rub into your foot, for example, might help take some of the pain away. So there are lots of things that can be done to hopefully relieve some of the symptoms, but they may come with side effects themselves.
Just to touch on gabapentin and pregabalin a bit more, these drugs are prescribed a lot throughout the world for neuropathic type symptoms. And, some people do find them an absolute game changer and they can be incredibly effective. But as you say, unfortunately, there's no such thing as a free lunch, and some people can get very woozy or even a bit confused on these agents, and they don't suit everybody. But certainly, Sally, we both prescribed both of these agents, very liberally, to be fair, over the years.
Yeah.
And they can be extremely effective. You have to sometimes watch liver function, and with the drug gabapentin, there's a particular way of building up the dose slowly and then de-escalating or reducing slowly, which takes some care. But we work very sort of carefully and effectively with our sort of GP and palliative care colleagues to sort of use these agents and ensure that they're monitored and used appropriately.
Yeah, definitely. And actually, I think often patients have concerns as well. In fact, we need to do another pod on this, don't we, Jam, on a sort of pain relief, because I think it's a really important area. But I think sometimes patients are concerned about needing long-term painkillers, and will they be hooked on them or be addicted? And of course, I can understand that rationale, but equally living with ongoing pain is not acceptable. And so we do often prescribe these treatments where they are very effective in the long term. People might need them for a significant period of time until hopefully their body gets better and their neuropathy fades. So don't be alarmed if anyone here is listening and thinking, God, I've been on those drugs for a while and they're what I take. And, that can be quite normal.
Sometimes how effective they can be is manifest by the way in which people say, I'm going to just try and start weaning the dose down. And they notice with gabapentin, for example, you drop down a tablet or two and it's like, oh man, my symptoms, have come back. And as you say, I think if they work and you don't have side effects, absolutely use them. And Sally, just to, I think, go back to your point about living with neuropathy or neuropathic symptoms for many years, we're not good at capturing that impact that can have on people's quality of life. And so to think about that at an early stage, again, is testament to the fact that we are thinking about people's lives in double-digit years now for a lot of people.
Yeah, absolutely. That's what we want, people to be well, living with myeloma, albeit that we can talk about the potential of cure, particularly to some individuals, but living with myeloma and living well with it. So it is really important that we all work together, I think, to get this right. Jam, I think I've said this to you before when we were speaking at a meeting a short while ago, actually. I'm almost getting to a point now where I personally view neuropathy, long-term neuropathy, as what we would call a never event, something which just simply is not acceptable for patients who are starting these drugs going forward in the future. And if it occurs, we need to do better, and we need to not allow that to occur next time and next time. And maybe that's a little bit ambitious, but I think what I what's going through my mind as I come out with these things is I want to make sure that I'm asking the right questions and sharing the right amount of information so that the people who are experiencing this symptom have the confidence to share it and know that they don't have to stick up with it. And there are things that we can do about it to hopefully make sure that it doesn't last and, it's not there for the long run.
What a lovely summary of how to end our discussion about neuropathy, Sally. I totally agree with you. I think this has been a really interesting discussion on neuropathy, and I hope people have found it helpful.
Yeah, me too. I really do hope so. And just to say that if anyone listening here is living with neuropathy, talk to your team. It may be that you might benefit from a neurology review, or there are other things that can happen. So don't just think actually you just need to stick up with it. Just talk to us and see what your teams around you can do.
Sal, it's great chatting to you again. I'll see you soon.
Yeah, absolutely. Take care, Jam.
This has been the Myeloma Minutes. We hope that you found today's pod engaging, interesting, and above all, useful and understandable. Please remember that this does not constitute medical advice. Thank you so much for listening. Please do feedback on what you've enjoyed and what you'd like more of. You can email us at themyelomaminutes@gmail.com, and we'll see you at the next one. Bye.